Hello, my name is Rachel Guberman-Hill. I'm Director of the Elizabeth Blackwell Institute for Health Research, and I'd really like to welcome you to our 2020 annual public lecture that we hold every year to celebrate the legacy of Dr. Elizabeth Blackwell. By way of housekeeping before I start, you can ask questions today using the Q&A function in Zoom. We're recording this session, but your cameras are turned off and your microphones are turned off as well. But you can access subtitles today if you'd like to by clicking the CC button on Zoom. That's on the Zoom taskbar. So it's my great pleasure to introduce the 2020 Elizabeth Blackwell Institute lecturer, and she's Professor Dame Sue Hill. Sue is the Chief Scientific Officer for NHS England, which means that she's head of profession for the healthcare science workforce in the NHS and associated bodies. Sue's also the Senior Responsible Officer for Genomics in NHS England. She leads developments in this area and she established the NHS Genomic Medicine Service. She also led the NHS contribution to the 100,000 Genomes Project. Sue is a respiratory scientist by background, and she has an international reputation for her groundbreaking research. So I know we're all really looking forward to this lecture today, and it's going to cover a lot of really important and incredibly timely ground. Remember that you're very welcome to ask questions throughout the lecture, and that you can use the Q&A function to do so. I know that Sue is looking forward to answering these questions in today's session, and she'll do so live after her talk today. So thank you, Sue, for joining us to give the 2020 Elizabeth Blackwell Institute lecture. I'm really pleased to pass the microphone over to you now.
Thank you very much, Rachel, and good afternoon, everyone. And I'm delighted to be giving this 2020 Elizabeth Blackwell Institute lecture on genomics and healthcare and new opportunities. Elizabeth Blackwell was a truly remarkable woman, and my next slide outlines the contribution that she made in terms of being a trailblazer. She was originally from Bristol, emigrated to the US with her family, and went on to become the first woman to receive an MD from an American medical school. And she led various healthcare developments, both in New York and then further up in New York State, around Buffalo and Syracuse. Later, when she came back to England, she became the first woman to be placed on the General Medical Council's medical register. And over her lifetime, she pioneered promoting education for women in medicine and women in healthcare in general. She set up the National Health Society and used the motto, "Prevention is better than cure," a motto all of us in healthcare live by. I'm now going to move into my talk and start with the context. And the context really comes back to those principles that were outlined in Dr. Blackwell's, pioneering stance that she took in healthcare back in the late 1800s. There are a number of challenges for healthcare systems wherever we are in the world, in terms of delivering affordable healthcare, having an ageing population, providing equity of access, delivering high quality care, and meeting the individual's need. And the future direction for healthcare systems is one that's much more focused on improvements to population health, and more of a preventative approach, so Dr. Blackwell's spirit, and on the other hand, increasingly personalisation of treatments and approaches so that we can ensure that individuals get the best possible outcome. If I can go to my next slide. Genomics encompasses the spectrum of testing, and the World Health Organization defines genetics as the study of hereditary and genomics as the study of genes in our DNA and their functions and related techniques. And a gene that we look at through DNA analysis is a region of DNA that encodes the function. And I'm going to be telling you about work that we've been doing to sequence all the genes, but all the genome. So all of those 30,000 genes, but also the information that's contained in between. But there are also important other elements of genomic analysis, including RNA, which actually sets out the implementation strategy in the body, then how that gets translated into the process happening, and then into something that we call metabolomics, or circulating products that actually tell us the end stage of a particular process. So if I go to my next slide, genomics has a real potential for healthcare, both in terms of delivering protocol-based medicine, both in terms of enabling us to move from protocol-based medicine into data-driven healthcare, from volume-based healthcare into value-based healthcare, and from a one-size-fits-all approach to better tailored and targeted intervention. And this gives us the opportunity to deliver a better outcome for patients in terms of prognosis, better diagnosis, to have fewer adverse events, to optimise treatment selection, to improve access to those treatments, to better disease monitor, and to ensure that individuals can effectively participate in clinical trials. And in the NHS, genomics encompass that whole WHO definition, from single gene to whole genome sequencing, all the genes and everything in between, and from DNA to those end products. I'm not going to talk about all of those today because we're some way from introducing those into the healthcare system, but that's our intention. My next slide really sets out that fairly recently the UK government published the Genomic UK strategy, and it set out a really ambitious place for the government to create the most advanced genomic healthcare system in the world, but underpinned by the latest scientific advances to deliver better health outcomes at a lower cost. And part of this is how we harness the power of health data. There are a number of different elements. One is diagnosis and personalised medicine. The second, again in the spirit of Dr. Elizabeth Blackwell, is a focus on prevention. And then the third is on research, and recognising that to underpin this, we need to develop our workforce, engage and have dialogue, support industrial growth in the UK to make sure we've got cutting edge diagnostics, and to maintain the trust that I'm going to come back to. My next slide sets out, though, that genomics is a global initiative with the potential for collaboration. There are over 70 different genomic initiatives in countries across the world, with over $4 billion actually invested in these activities. And bringing them together are two organisations, one the Global Alliance for Genomics in Healthcare, that's starting to focus on how do we set standards to enable responsible genomic data sharing across the world to really improve outcomes for patients. The second, that I'm very actively involved in, sitting on the executive committee and leading several work streams, is the Global Genomic Medicine Collaborative, which is to foster global collaboration to really drive genomic medicine into healthcare systems. My next slide is really starting me on a journey to tell you about how genomics have driven transformation in healthcare systems. The 100,000 Genomes Project that was initiated by the then Prime Minister David Cameron as a legacy project after the London Olympics actually wanted to ensure the UK remained world leading in terms of its use of DNA and DNA analysis for cutting edge healthcare treatment. It set up a project and to whole genome sequence, so those 30,000 odd genes plus the bits in between of 100,000 people with rare disease, rare and inherited disease, and with cancer. And this was divided in terms of how this was delivered into several different components, but two of which are on this slide. Firstly, in NHS England, I established 13 NHS Genomic Medicine Centres, really centred on the patient element. On the right-hand side, Genomics England, a company that was set up as part of the project infrastructure and owned by the Secretary of State, set up the ability for that sequencing to take place in a sequencing centre and for samples to be put into a biorepository, but through an informatics and data architecture, set up the ability to be able to provide data to researchers and to academics and industry partners through the concept of a reading library rather than a learning library. You can see that there are over 122,000 genomes that were samples that were collected and received at the UK Biocentre. Most of those collected were in rare disease, but 36,000 in cancer. This represents around 18,000 people, because people with cancer gave both a blood sample as well as a sample of their tumour. There are now over 107,000 genomes in the research environment. And because individuals consented at the very beginning to provide their longitudinal health data, there's primary clinical data now on nearly 90,000 participants. This remains world leading despite all of that investment that I talked about earlier in other countries across the globe. My next slide really set out that what was unique about this, the way this project was constituted, was the role of participants that enabled patients to be put at the heart of the project. And what I'm delighted to say is that one of the local Bristol residents has been chairing the participant panel for the last few years. She was a civil servant by background, has a son with a rare disease, and that's Gillian Hastings, who's done a truly remarkable job. But what this has enabled is for that patient, that participant input to be put into everything, whether it's in that discovery forum with industry, looking at the data that's been collected but in a de-identified way, whether it's in researchers accessing this, or whether it's thinking about the ethical concerns. They've really, really shaped the project and continue to shape the project and its outcomes to this day. The next slide outlines that the project focused on rare disease and cancer because these were the areas of the most unmet need. There are 6,000 rare diseases that have been identified. Only a quarter of those have a molecular basis for their disease. In this project, 1,200 disorders were studied. And by increasing the way in which individuals with rare disease were characterised using something called HPO terms, and if we got more of those, we got a much better outcome. In general, in rare disease, over standard of care, patients received about 25% of patients received a diagnosis, which increased to 40 to 50% in some disorders. And in this project, it showed that sometimes this brought to the end a diagnostic odyssey of years in many patients, costing an inordinate amount of money within the healthcare system. So the key message of this is whole genome sequencing does deliver better outcomes. If you characterise patients very carefully, then that increases diagnostic yield. On the cancer side, that's on the previous slide, sorry. Yeah, that's it. If you could broaden it out for me. The cancer, there were 24 cancer types included, and genomic changes were found in 136 potentially actionable genes across all the solid tumours that were studied, and that was 5,700. And so 50% of those have a known actionable or potentially actionable mutation, which is information that we didn't know before. But cancer, of course, as a result of disordered genomics. But this was groundbreaking in terms of how we think about using genomics in cancer going forward. My next slide sets out that, of course, it's the outcomes that matter. And here, Jessica, age 4, took part in the project. She'd been having really difficult to control seizures for many, many years, lots of different investigations, but a genetic variation was found in a gene that makes a protein that transports a particular type of sugar into the brain. When these patients who have this GLUT1 deficiency have a very low carbohydrate diet, a ketogenic diet, and many of you may be on Michael Mosley's 800 diet, you'll know that's a ketogenic diet, can actually help reduce the number of seizures. And indeed, this is what happened to Jessica. But on the right-hand side, this tells you what really matters as well, which is when our laboratories don't really know whether the genomic variant that's been observed is really clinically relevant, the Genomics England Clinical Interpretation Partnerships, working with academics and industry, and you can see that data on this slide, have actually returned 141 diagnoses to our NHS laboratories since January 2020. And this is contributing to patient care. So these were unknown at that time, genomic variants that have been found that could be actually important. And many of these are important and are enabling people to move into new forms of treatment or further investigations. So it's that bit of aligning clinical care with research endeavours that's really important as we come and look forward to the future. My next slide really outlines, though, that there's still more to do to complete the project. There's a real question about how often we should reanalyse whole genome sequences and what the potential implications are. There's a need for a real focus on how we use whole genome sequencing to improve care beyond the primary question that was being asked about the patients. For example, whether they are potentially going to get adverse reactions to drugs that they might take, called pharmacogenomics, or whether we can find anything else in their genome that might mean that they have an inherited disposition to certain diseases like cancer or high circulating fats in their blood called familial hypercholesterolemia. And of course, what we need to do is really understand the impact on NHS services and make sure when we roll this out, there is an equitable approach across the country. Where have we taken this then? My next slide sets me into my next section of my talk, which is creating the future NHS service. And the long-term plan for the NHS in England has set out the focus on genomics for the next 10 years. It's committed to sequencing 500 whole genomes by 2023, for all children with cancer to be offered whole genome sequencing, to extend our access to molecular diagnostics in cancer, and to increase the testing for that inherited condition I just referred to called familial hypercholesterolemia, or high circulating fats associated with sudden cardiac death, particularly under the 50-year-olds. And then to, in terms of research, to really continue to press to link and correlate genomic and clinical data together to make sure we get the best possible outcomes. In October 2018, if we go to my next slide, what we did was launch the Genomic Medicine Service, and this brought together all the developments in genomics in the NHS since it began back in the 1960s. That's the genomic laboratories, for example, and the genomic services, right through to the learnings from the 100,000 Genomes project. And we set out that we would launch and introduce a genomic medicine service that provided consistent and equitable care, knowing that there'd been variability across the country. That's variability in terms of access, but also in terms of quality. We wanted a national approach to patient consent, patient and public involvement against the backdrop of a strong ethical framework, working to common national standards, and that includes common, for example, contracts and the way we can monitor data so we know whether access has been is equitable. To introduce a consolidated national genomic network made up of 7 genomic laboratory hubs, with partnerships across local providers across geographies of between 5 and 10 million, building on the NHS Genomic Medicine Centre model and integrated with clinical specialties across the care continuum. A single mandated national test directory for the NHS that's linked to the payment system, covering all technologies from single gene to whole genome sequencing and inclusive of cancer, and a single national genomic knowledge base to continue to ensure that we support research and discovery, but we improve outcomes for patients, and a single coordinated unit in NHS England. My next slide just outlines what this actually looks like visually. So those genomic laboratory hubs, that national genomic test directory, informed patients and involvement in the creation of their services, a link to clinical genetic services and broader clinical teams, but at the bottom, a national whole genome sequencing provision that's actually delivered through a partnership with Genomics England, and where patients provide their informed choice stroke consent. That data will go into a UK genomic knowledge base in a de-identified format in the same way I outlined earlier. And then what we're about to announce very soon is Genomic Medicine Service alliances, which will provide multidisciplinary clinical leadership to embed genomic medicine across end-to-end patient pathways, aligned to those genomic laboratory hubs. This is a world-leading infrastructure. Nowhere else in the world has done this, and many other places have. It's very difficult to even contemplate to do this. My next slide sets out that within the Southwest, there are really strong partnerships. There were 2 genomic medicine centres as part of the 100,000 Genomes project, and this just shows the West of England Genomic Medicine Centre and what it covered across the Bristol and Bath and surrounding areas. There's now a Southwest NHS Genomic Laboratory Hub based at the Bristol Genetics Laboratory, working with the Exeter Genomic Laboratories, but servicing the whole of the Southwest, right through to the Isles of Scilly. And then, as I'll be scoring actually towards the end of this afternoon, will hopefully be a Southwest NHS Genomic Medicine Service alliance. And you can see there the partners who are going to be part of that. But there's an important link here with the university and academic providers across the patch. My next slide says that in terms of this, the testing that will be undertaking, the Genomic Medicine Service and Test Directory has a deliberate focus on the whole continuum, whether it's disease-focused, informing treatment decisions, whether it's population-based, or whether it's predictive. And that means it will cover from targeted testing to panels to exome sequencing to whole genome sequencing. So at the bottom end of this spectrum and targeted treatment, this will also include cascade treatment for those inherited diseases that makes it more predictive and preventative. But at the other end, we will be introducing to the service 21 rare diseases that will move into whole genome sequencing for the very first time, as well as a small number of cancers in addition to all those childhood cancers. My next slide and my next 3 slides will set out services that are being delivered in the Southwest by 3 remarkable women in the spirit of Dr. Blackwell's legacy. The first is the National Rapid Exome Sequencing Service for young individuals in intensive care, and that may have a likely monogenic or genetic cause for their disease. We commissioned this service from Sian Ellard at the Royal Devon and Exeter Hospital in October 2019. There's 520 referrals to date, and a diagnosis has been returned in 37% of the patients, and at least 10 cases where a genetic diagnosis has changed. And this just tells the story of Ellie Rose here, who was ill until she was 18 months old when sequencing through this service revealed she had a condition where her diaphragm was paralysed. She's now receiving treatment and is progressing well at home. But we've extended this service to include children with a severe COVID-19 phenotype. There's been a small number of referrals to date, but in some patients, the potential for the change in genomic variant to be a cause of their disease, potentially opening up treatment options. Our second remarkable woman and a remarkable service that's been delivered is the Southwest Familial Hypercholesteremia Service, delivered by Maggie Williams at Bristol. And I'm not going to talk through this in any detail, but Maggie's been, and the team have been, a real pioneer for introducing familial hypercholesteremia genomic testing. They've really driven sharing expertise. They've driven the way in which genomic variants should be classified. They've really driven case finding, and they've done much of the testing for the rest of the country. So a really important development, because this is estimated to have a prevalence of 1 in 250 in the UK and leads to, as I said earlier, increased risk of acute cardiac events. My third remarkable woman, who's a recent import into Bristol and to the Southwest Genomic Laboratory Hub, is Rachel Butler, who's really came in and, together with other colleagues, are revolutionising the way in which cancer services are going to be delivered across the Southwest, with a much more comprehensive offer, not just for all the tumours, whether they're solid tumours or haematological malignancy tumours, but also different ways in which we can analyse, for example, lung cancers or for colorectal cancer. And this will start to bring the testing across the peninsula, across the Southwest, all into Bristol for this remarkable service. Now, as I move into my next slide, this says that part of what we're doing as we move forward is establishing a shared platform for diagnosis and research, just like we've done before in the 100,000 Genomes project, but this time focused on the NHS Genomic Medicine Service, and setting up a research collaborative of all the Genomic Medicine Service alliances, genomic laboratory hubs, will enable us to facilitate and coordinate research and drive improvements in diagnostics, in treatments, in discovery, and in evaluation. And all genomic data will be deposited into that library we're creating so that it can be used for continually sort of re-evaluating our interpretation of genomics to make sure that we get the best possible outcomes for patients. Of course, this is based on our patients actually providing their consent at the very beginning, but also in developing a shared informatics and data platform that will sit across the NHS Genomic Medicine Service in conjunction with Genomics England to make this happen. And my next slide just sets out this interface with research driving clinical improvements, with on the research side on the right being Genomics England, on the left-hand side healthcare being the NHS England. And what we will be doing together is making the loop work as an efficient, robust and scalable system to help patients, to help healthcare teams, and to help our system. And it's particularly important at this interface, that intersection from research and healthcare, that will really ensure that we can enhance diagnostic interpretation. I'm going to move now into the next part of my talk. And before I do that, into just saying, I wanted to mention also one individual from the South West, from Bristol in particular, and that's Andrew Mumford, a haematologist who's really led our genomic achievements in haematology, both in terms of driving forward research into people with blood disorders in the 100,000 Genomes project, but also how this can be driven in terms of clinical translation into the service. So that's that infinity leap actually being in action already. So the next part of my talk goes into how we can use genomics to personalise medicine and to personalise treatment. This is dependent on mainstreaming, a focus on end-to-end pathways, a vision that we all know that Dr. Blackwell held, from prevention through to early identification, to diagnosis, treatment selection, and monitoring and recurrence. And recognising that genomics has a role to play in all of these, but the important part is to bring together genomics with a whole raft of other clinical diagnostic tests and clinical data that will really help us move into personalising treatments. My next slide outlines that just a few weeks ago, we introduced and announced a pilot that will potentially revolutionise the way we can detect more than 50 cancers. And you can see the quote there on the right-hand side from Matt Hancock. And this is a project that will be delivered in conjunction with GRAIL, that will start to look at their simple blood test using targeted genomic sequencing in a range of cancers, both in those that may have no symptoms, and therefore we may pick it up much earlier before people even have symptoms, but also in people that have symptoms but where no known cause can be found, and where they're particularly difficult to diagnose, such as head and neck, ovarian, pancreatic, esophageal, and some blood cancers. So this will start to bring into the NHS that bit that Dr. Blackwell said at the very beginning about prevention is better than cure. My next slide sets out that we have lots to do in terms of how we introduced a standardised approach in terms of those end-to-end pathways to improve outcomes, whether it's in breast cancer to identify genetic drivers and then the likely toxicity of any primary treatment or future treatment options, how we use genomics in colorectal cancer, where we know, depending on the cluster analysis of the genomic variants, it leads a surgeon to, or a person looking after a patient with colorectal cancer into different types of approaches, including organ preservation. In neonatal onset diabetes that Sian and the team in Exeter have led, where we've got many cases that are misdiagnosed and still some that have not been found. And then also in pharmacogenomics, where we know that preliminary when we think about what this might mean if this is associated with adverse drug reactions. And so understanding that and doing more work on that will be critical as we move forward. So lots of work to do to ensure that we can standardise that end-to-end pathway I talked about in a minute. My next slide actually outlines that what this means in reality. And to really do this, we have to bring all this data together and use this to ensure that there's the correct delivery of the personalised treatment according to national guidance. So it's not an easy matter, but it's something that if we get this right, and we're committed to this in our improving outcomes for personalised medicine strategy document in NHS England, this will ensure that patients get the right treatment with a lower amount of adverse reactions. And my next slide just really sets this out, saying this will end the one-size-fits-all era of medicine, from a traditional approach with a broad diagnosis where everybody receives the same medicine and typically it's only 30 to 60% effective, to a more personalised approach where it's tailored to match an individual's makeup and response, more effective, fewer side effects, better value for money for the £17 billion that we spend on drugs in the NHS every year. My next slide just outlines, and if I could have this on a wider screen, how when we get it right, it is very individualised, but it can have a tremendous impact. This was an 11-year-old child with a brain cancer who had a whole genome sequencing. The patient relapsed shortly after having had the whole genome sequencing. There was an urgent review which revealed a novel particular BRAF fusion, and that fusion wouldn't have been detected by conventional testing. The clinician applied for a particular type of therapy following discussions with experts in brain tumours in Germany. And then after conventional therapy, the family was given that opportunity to access that personalised targeted treatment with a better outcome. And that's just one example of how personalised it can actually get when you have this extra level of detail from genomic characterisation in cancer. My next slide just outlines, as we move towards the future, there are novel concepts for how we start to personalise cancer medicine by using lots of computer modelling in real time alongside standards approach to clinical trials, but means that clinical trials can be much more reactive. If I can move then towards the end of my talk and onto my next slide, just saying the vision for personalised medicine is that genomic testing is included within medicine's access pathways. It's linked to priorities for genomics and medicine's optimisation. We use data sets from lab and clinical purposes to ensure equitable access, and we incorporate pharmacogenomics into routine prescribing. If I can move on. Key challenges to embedding genomics in mainstream care remain in terms of how we develop our workforce, and the genomics education programme in Health Education England has been critical in understanding how we use core genomic knowledge and concepts, how we contextualise those concepts in a post-registration sense, and how we embed those in clinical practice. And you can see, in terms of the resources that are shown along the bottom here, the data that's been generated from all the access to those resources. My next slide sets out that if we really want to build a learning community of clinical genomics, we have to continue with education and training. That's at the core of the change in knowledge and embedding, and this is just some data taken from Australia showing pre-2016 before their Australian Genomics project, and then post in 2018 when they'd done a lot of education and training. And my next slide really sets out that we have to retain and build public trust though. And in the Ipsos Mori study that was done, it recognises that we had to focus on 3 elements linked to reciprocity, altruism and solidarity. And that within this approach, some of them are red lines, like the use of not selling data and not genetic engineering. But this is a critical part of ensuring that we remain true to ourselves. If I go to my next slide, we have to work within an ethical framework, and the debates are gathering in terms of whether we should sequence at birth. And indeed, the study at BabySeq in Boston is already starting to do that and looking at how this might replace usual hair-pick screening, but also how it may diagnose rare disease earlier and therefore prevent the number of under 5-year-olds dying early. My next slide sets out that here in the Southwest, there's been some tremendous educational partnerships led by Mel Watson that's both looked at how staff can be upskilled, how clinical and professional staff can be focused in terms of their training, how the genome can be socialised, and how developments can be introduced in conjunction with cancer charities, for example. And of course, at the University of Bristol and the University of Exeter have both developed a whole raft of different programmes to support the multi-professional team. My next slide. I just want to spend just a couple of minutes, and then I'll be at the end of my talk, about genomics and responding to a public health crisis. So genomics and SARS-CoV-2. There have been 1.57 million cases so far and over 57,000 deaths across the world. If we go to my next slide, COG UK and this particular consortium was established earlier this year to generate scientific evidence to demonstrate where genomic sequencing of this virus can bring benefit to public health. And in doing that, establish the evidence and the infrastructure to move into a routine service within the overall test and trace programme for public team actions. My next slide sets out that this is a partnership. It's funded by the body across the bottom. The Wellcome Singer has been critically involved, as well as the 4 public health agencies. But what the graph on the right shows is that the UK have sequenced more than 50% of SARS-CoV-2 genomes than the rest of the world. So they've done over 50% of the genomes that have been sequenced across the world. My next slide shows that what the focus has been on transmission and outbreak investigation, mutational analysis and tracking, sentinel genomic surveillance, and support for projects such as Genomic. If I can go to my next slide, and I've got 2 slides that I'm going to cover very quickly. First of all, just to give you some very breaking data, some of the mutations under surveillance to a particular protein on the surface of the SARS-CoV-2 virus called the spike protein. And what we know was when the virus first emerged, this wasn't present, this particular mutation called D614G, but it's now almost ubiquitous in all strains. And this replacement is associated with higher viral loads and a younger patient age. And this increasing frequency is consistent with a selective advantage by the virus. And there's information on the right-hand side of this slide to show that the increased transmissibility of some of these things that we're actually seeing may have originated in Europe. My next slide just shows some data from Scotland, with an analysis of genomes to mid-August showed around a quarter of all positive samples, showed that there were independent introductions of the virus into Scotland. Following the first lockdown, most of those changes in the genotype that were circulating in the population became extinguished, and few persisted over the summer. But the second wave was caused by new changes in the genotype introduced predominantly from countries outside of the UK and most likely associated with holidays. My next slide just says there's a key project that's starting to look at both the virus as well in the COG UK database, but in the host as part of Genomic in severely ill patients and mildly affected patients, and then comparing those outcomes with the Genomics England dataset and the UK biodataset. And this next slide just shows that in a paper that was recently published, that there were 7 genome-wide specific loci detected that was associated in the host with poorer outcomes. And some of those, for example, are associated with the way in which certain types of blood cells called monocytes migrate into the lung. So this will start to give us information about identifying the genetic reason for why some people develop mild disease and some develop more severe disease. So moving on, and just to complete, in closing, if I can go to my next slide, there are a number of outcomes and impact that I've outlined in terms of eligibility for clinical trials, better diagnosis for patients, more personalised treatments, patient, public and healthcare professional education, an integrated genomic repository, and new partnerships, importantly, between patients, industry, academia and the NHS. And there are many opportunities, not just in the diseases that I've spoken about, but in other diseases that we'll see over the next few years. And to conclude, I'd like to finish with a quote from Elizabeth Blackwell herself. "It's not easy to be a pioneer, but oh, is it fascinating." And I can definitely subscribe to that quote and say this really is fascinating, but it's also life-changing for many people. Thank you so very much.
Thank you so much, Sue. That was absolutely fascinating. You've covered a lot of ground and you've given us a really clear sense of recent innovation. And I'm sure that Dr. Blackwell would have been right at the heart of this work had she been here today. So in the spirit of thanks, at this point, if we were on stage in Bristol, what we'd like to do would be present you with a piece of Bristol blue glass with a piece of engraving on it. And that's partly because this lecture is supported with a very generous donation from descendants of Dr. Elizabeth Blackwell. So we've sent you a piece of glass in advance. So we very much hope, oh, there it is, fantastic. We very much hope that you will enjoy having that blue glass in your home or in your office to remind you of today.
I most definitely will. And having been brought up in the Southwest, it obviously means a lot to me as well.
Fantastic. Now, Sue, we have questions flowing in thick and fast. So just a reminder to our audience, if you've got a question you'd like to ask, pop it into the Q&A box on Zoom. We probably won't have time in the next 10 minutes to cover all of them, but we will do our utmost to get through them. And what I'll do is I'll read them out as they're written so that Sue can have them as if you were in the audience today. And first of all, people are saying very warm thank you for the informative session. So thank you very much indeed, Sue. So the first question I have here, and I'm going to read it directly so I get the wording right to be true to the audience, is how do we move genomic medicine from those who are ill to healthy carriers? And in doing so, can we identify those at risk and so initiate preventive measures?
So that's quite a broad question. I mean, we are addressing this in some way, as I spoke about it in my lecture. One was when people are having genomic investigations like whole genome sequencing for other conditions, that we could find out if they've got an inherited disposition for some cancers. But I think where we need to go towards is more, and I hate to use the word screening, but more targeted testing of certain populations to really understand whether they have an increased risk of carrying certain genes, for example, for cancer or for familial hypercholesterolemia. And although I didn't go into detail, we are starting to work nationally on a familial hypercholesterolemia program that will start to see more extensive screening in the community to try and find these cases. And that's essentially where we will have to go. But that's also why there's an interest in newborn screening and whether having a genome on someone's record may well be something that would mean that we could move into a different type of preventative healthcare approach. But there's lots of public debate that needs to happen in that area.
Fantastic, thank you. So the next question is probably quite a nice follow-on from that. And it asks, it says, whole genome sequencing represents a lot of benefits, but no technology is perfect. What are the plans to address the shortcomings of whole genome sequencing when it's rolled out across England? And then there's an example given. For example, when looking at disease caused by large or repetitive genetic rearrangements. So what are the plans relating to new technology that could pick up the slack?
Yes, so one of the things I didn't say, and I meant to say as part of my lecture, what we're talking about at the moment is using a particular short read technology. But how I feel we should move in terms of our service is a bit like we've done with imaging, which is have multimodality DNA analysis that might see us analysing whether it's a tumour, whether it's a patient with rare disease, whole genome sequencing with both long read and short read technologies, but also bringing together a whole raft of different genomic testing to make sure that we can try and find the cause of that person's disease if there's other evidence that suggests that it might have a genetic makeup. And indeed, there's some very good evidence from North America showing that why we need to move to this multimodality approach. And we will also have to think about where we use whole exome sequencing as well in this. But part of our challenge is at the moment, although the price has come down dramatically, which is why we can introduce whole genome sequencing, we need to get it closer to the patient and reduce the cost even further, and also reduce the turnaround time even further.
Thank you. So then the next question complements the previous one quite nicely and asks about other types of data. And the question reads, what types of data other than genomic data do you think we'll need to move towards data-driven healthcare? And the questioner says that they're thinking particularly of outcomes, coded diagnostic and symptom data, for example. So how will these data need to interact?
Yeah, so all of that needs to come together. And indeed, in terms of the database that Genomics England will be continuing to curate and annotate, if a patient provides their consent, then they consent to their longitudinal health data to be pulled. Now, that data may not be in enough detail to actually properly characterise an episode. And that's why it's really important at the point that genomic testing is done, that it's done in a very, very characterised way, but that we equally have the ability to pull in data from all the different diagnostic services and to start to capture outcomes data. That means we can understand whether there has been an impact in an individual patient. Within the Genomic Medicine Service, we'll be starting to collect outcome data, as well as understanding whether people have indeed had access to testing. And we will be linking to, across the country, what are called regional medicines optimisations committees, to make sure everyone with a given mutation, if there is a targeted treatment available, that we know that they've been considered for that targeted treatment, or that they've been considered for entry into a clinical trial.
Great. So there's a question about research studies, particularly the GRAIL study. And the question is that the questioner has read a lot of criticism about the ethics of running the GRAIL study as a pilot when sensitivity is poor for stage 1 cancers. Do you have any comment to give about this?
Well, I think that's the very reason why we want to do the pilot, actually, is because there are conflicting results. There are lots of results have been presented at different places across the world. But if we look at, in a pilot in both essentially naive people, so people who aren't symptomatic, and people who are symptomatic or on the 2-week cancer wait, then we can start to get an understanding about where this particular test may be utilised in the healthcare system. And it's a pilot for a very good reason, which is probably what your questioner was getting at.
I think so. So then that moves us to think about treatment. And there's a really interesting question from the audience about kind of personalisation of treatments. And to be specific, the question asks, how will personalised tablets work when in hospitals, tablets and pills are delivered in rounds at fixed times rather than at times that they might need to be delivered, such as before and after food? So a question about treatment.
Yeah, so I mean, I think the most important thing to start with is that we'll focus on drugs where there are known adverse drug reactions if they carry a genomic variant. And indeed, on the slide that I put up about cancer services in the Southwest, I mentioned, or what was mentioned on there was the testing for something called DPYD, which is a genomic variant associated with the fluoropyrimidines, a particular type of cancer chemotherapy, that sometimes there can be fatal adverse toxicity effects. So that is being rolled out. But in terms of personalisation in terms of dosing, I think we've really got to understand what this actually means in terms of dosing pre and post food, in terms of when people take it within a day. But because we've got pharmacists now heavily involved in the Genomic Medicine Service, and it truly is multi-professional, then we will ensure pharmacists will be a key conduit to making sure that the individual does get the targeted treatment. And we know from chemotherapy treatment, though, and for many other treatments that need to be given at a particular time, this can be done in the health service. It just needs to be done in a systematic way.
Fantastic. Thank you, Sue. I think we've got time for maybe 2 more questions. So there's another one here that says, thank you for a fantastic presentation, and then asks about NICE guidance. And the question asks, are there any plans to incorporate pharmacogenomic decision support or stratification as part of routine NICE guidance?
Well, we're working with NICE to work that into the guidance to understand how it would work. And particularly, I didn't talk about it today, but we have earlier this year, NICE introduced, licensed 2 drugs for, or provided guidance for 2 drugs for NTRK gene fusions. And what we have started to do, that actually put us in a very different position with NICE about the genomic testing that needed to be done and how that would fit into the guidance and how it would be treated in terms of the economic analysis. So we've got the start of how pharmacogenomics could be introduced into NICE guidance, and that's what we'll be doing as we move forward. And on my vision for personalised medicine, the bottom actually part of that just said broader interaction with other system partners like NICE and like MHRA.
Thank you, Sue. So a very final one, which takes us kind of back into kind of the big picture territory again, and it's about cost. And the question asks whether individual treatments will increase the cost of drugs.
So individualised treatments, with all the new treatments that are introduced, then there's a cost analysis done. What we know, though, already, that by personalising treatments, some treatments can be stopped. And indeed, in some of the diabetic examples that Sian Ellard from Exeter and Andrew Hastesy can provide, will tell you that sometimes people have been on insulin injections, but actually when they've had genomic analysis done, they can be sort of changed to relatively low costs sulfonylureas. So there will be different types of approach. There may be higher cost approaches, and CAR-T therapy is a very good example. And that's a good example of where we do need to do more extensive genomics to understand when that drug in B-cell lymphoma, for example, where it won't work. But this will be about balancing what could be access to more expensive treatments with access to treatments that are lower cost but have a better outcome.
Fantastic. Thank you so much. And thank you to the audience for all of those fantastic questions that you've sent in. I'm sorry we didn't have time to answer all of them. I know Sue says that she's very happy for you to contact her if you have a question that we were unable to answer today. Thank you. So it just remains for us to wrap up, to thank everybody for coming today. I know there's several hundred of you out there. Thank you for joining. Thank you so much, Professor Dame Sue Hill, for giving the 2020 annual public lecture of the Elizabeth Blackwell Institute. It's been absolutely fantastic. I've learned a lot. I'm sure everybody else has as well. And if anyone would like to revisit the lecture, it will be recorded and it will be available online on the Elizabeth Blackwell Institute website. Sue, thank you. Final word to Sue.
Thank you, and it's been an absolute privilege and pleasure to give this lecture in honour of a truly inspirational woman. Thank you so much.
Thank you, Sue.